there's going to be a couple different areas we can step patients up, and we'll talk a little bit about that. So my name is Joseph Landavaso, and I'm a research assistant here with the center, and I'm also going to serve as the care manager specialist liaison. So whenever we're talking about connecting you with a specialist, I'd be the person that you're going to communicate with. And so some of it is we're still working out some of the kinks, like we talked about earlier today. But as far as getting a workflow put into place, we have a really good plan going forward. So we'll talk a little bit more about that. And this is Dr. Deidra Cruz, and I'll let you introduce yourself.
We met last week.
Yes?
Yeah.
Yep.
And our health disparities are.
Yes.
But she's right there.
Yeah.
So and this pretty much outlined the objectives. So we'll talk about the rationale, what the timing is going to look like, how soon can a patient be stepped up, and then from there also what the process is going to look like. So how do you identify when a step up is needed? Who do you communicate this with? What are the different forms and documentation that'll be taken that you'll have to do? And also, like, you'll be following up with either the specialist or CHW, and so we'll talk a little bit about that. So the purpose of this, obviously, is some patients have a little bit more complex chronic diseases and might have medical issues that need to be resolved through specialists or through some consulting of specialists. Also, some patients may need help with becoming engaged or empowered to participate in their care, and also the family might be where a community health worker could be valuable. And then also just addressing some of those barriers they have to care. So the different options we have through Rich Life are the community health worker. Your colleagues are here in the room with you, and then also we have the specialist core, which would be, we'll actually talk about the specific ones we have a little bit later in the presentation, but more for medication complications or complex chronic diseases and things that are more medical related. And then just so that you have a sense of what we're envisioning, a patient at any point in this process could have a care manager only, could have a care manager and a community health worker, could have maybe a care manager and a specialist only, or maybe a care manager, community health worker, and a specialist. So this is where we'll be making decisions along the way. So for the timing, we're seeing that at 3 months, after 3 months of care management, if the patient's still in control, that's when you'd be making a determination whether or not a patient needs to be stepped up and to whom that they would be stepped up to. If you see on the far right-hand side, I've gone ahead and in your binders you have this document toward the back in the appendix. And what this does is it outlines the timing itself and then also why a patient would be stepped up. Like some scenarios why patients would be stepped up to the specialist. And you should take a look at this when you're making that determination and deciding who they would be seeing. There may be some exceptions, so I'm sure that you all can identify patients right now that you have in care management who may not be controlled in some of these variables or that metrics, and you're saying, well, like they may need to see a specialist like right away, like because they've been a harder case that you've had for a while. And you might say, even with care management, it's not going to make anything better. Some of those exceptions, those patients could be stepped up at 1 month instead of 3 months, and also you would be looking at that specialist consultation form that I just showed you on the previous slide to make that determination. So what is the process going to look like for the CHW? So stepping a patient up to the CHW. So if it's a 1 month step up, you're gonna want to first confirm that the patient's willing to work with the CHW, and then also the patient has to meet at least one of these conditions. The care manager services alone are not appropriate to address the patient's concerns or the patient's circumstances warrant more immediate support. That's when you could do a 1 month instead of the 3 months care management. And we just outlined some of the things here. Like some things that would take you to a CHW might be they're having issues with transportation or housing, or maybe they just need some social support.
Question?
Yeah.
So if they have those problems identified when we do the initial visit with the CHW, they can't go to the CHW right away?
So they'll have that first intervention visit, and they will get to meet CHW, but it would be up to that first month. So you have so if it's a patient you see as a good candidate for having a CHW, we're asking that at month 1, if they're not controlled, if the small interventions you've had as their care manager are not enough, then you would step up at 1 month, and they would be the patient who would be that exception to the 3 month, because otherwise we'd be asking for at 3 months stepping up.
What do you mean not controlled? You mean the blood pressure, or you mean the problems? Like
Blood
if they have
pressure.
transportation and housing problems and whatever at the initial visit,
So
you don't want them to go then.
there'll be some goals that, so you'll set goals with the patient themselves, you'll talk to them as part of the assessment that you'll do. And so when you're talking about achieving those goals, at 1 month you would be talking with them to see if they've been able to achieve some of those goals. If at that point you're saying, well, they have some of these other barriers that are holding them back from there, then you can decide to step them up to a special, or a CHW. But from what I think I'm hearing is that you're saying that you might be able to identify at day 1, like they could use a CHW.
We don't wait. No, we don't wait.
Like if they say I can't afford my blood pressure medicine because I can barely pay my light bill,
Right.
and
And you wouldn't want to wait that 1 month.
No.
Okay, yeah. And this is great. This is something we can talk a little bit more about and see where we are as far as flexibility with that protocol itself. But for now, like, this is what we outlined, being with the timeline with patients coming in, and we didn't see the CHW starting the intervention with every patient. It was more like a tiered approach.
Right, with everybody.
Yeah, but we'll talk a little bit more
Yeah,
about that.
because when we identify a problem, you know, especially for us as being nurses, we have to address something like utilities, or if they need social worker, or something like that. When we do our assessments, that's when we're looking for immediate needs to be taken care of first. It's just like NASA, we take care of those lower issues first before we can address the blood pressure and all that stuff. So it doesn't, to me, I can't wrap my mind around waiting a month. If I identify these problems, I want to address that, usually within less than a week. I've reached out to a social worker, or I've gotten resources myself and I've called them back.
Think of this way, though. You're thinking of our normal patients. These are patients that have been called by the researchers, hey, we're having this study, that. They probably aren't the ones that are going to agree to participate if they're having immediate crises like what we're used to dealing with all the time. You're probably going to have
train wrecks, yeah.
patients a little bit different that want to be in a research study.
And part of your assessment too
Maybe
is
or
you're going to
maybe
ask them.
not.
Maybe or not, I don't
Yeah,
know.
maybe or maybe not. I think the thing about it is once we do the initial assessment, I think it's just the fact of that whole like 1 month period to wait. So we could have like a couple of patients that we've seen, and we say, okay, based off of my assessment, this patient not only needs access to housing, but they might need access to transportation, so forth and so on. And so sort of waiting for like a 1 month to then pass that along. And then I'm thinking about like the assessment, the community health worker assessments that they have to do, like because they sort of follow up, and not even if they meet with the patient like right when or like right after we meet with them, but if somehow or another they could sort of like look at our assessment and sort of gear themselves up for the patient
Like
prior to
brainstorming,
so just like look at our assessments, we sort of like talk, converse with them about the patient's needs, and then they can sort of on their own within that month's time gear themselves up to sort of try and find a way to meet with the patient and help work on some of those problems.
And that's why then prior to the CHW actually having that meeting with the patient, we're trying to work in a time to meet with the CHW to talk about the patient themselves and to review those notes that you've taken, because you look in the NCQA, that the form that we're going to have you filling out, a lot of these questions are asked in there, and some of them are about some of these social factors. And so you're going to have that opportunity to not only talk with them, but maybe share the notes with them so that they can.
So maybe like once we like do the initial assessment, we find out what we find out, we then relay that information to your community health worker when you can, or however you can, and then they themselves will have a month's time to
Of
sort
course,
of.
if they're there
follow
for
up.
the initial assessment, they're gonna know
Already
that.
know that.
Right,
But if they're
right.
not.
Yeah.
And
They
I know we
also-
had discussed earlier about the possibility of the CHWs and the case managers having access to read the notes in Redbox. That would help the CHW not having to repeat some of the
Yeah.
information, and they can also know what, like you said, gear themselves up to
Yeah.
address some of those needs.
Have you guys figured out how you're gonna, maybe you haven't, but how you're gonna take the assessment from Redbox and then put it into Epic?
Well, we can't, because they're, on their side, they're still working out.
Okay.
Yeah, so we're kind of
okay.
waiting to see
I
what the
see.
research
So
side.
they would need
So,
like
yeah.
that to be able to look at your assessment.
Yeah, we do have the needs assessment that the community health worker will also be doing with the patient. And some of those questions can be, filled in, and so maybe that's part of the process would be to review the care managers, the NCQA, and actually
Mhm.
transfer the information, gives them an opportunity to do some brainstorming,
Mhm.
but also to fill out some of the
Their
form.
assessment,
Yeah,
yeah.
and that could be something we build into this. We would just have to talk a little bit more about that.
Yeah.
Could I ask a question? So I think, I'm assuming that when you think about your patients, right, that there are gonna be people there are gonna be many patients that have circumstances that a community health worker obviously would be helpful for trying to address. I guess the sense that I would have is that most of those circumstances would be old and not new, right? Like they would probably have been something that
Right.
has come to the attention of the clinical practice where they are, right? And maybe a social worker has been working with them or something like that. I think what we're thinking here is that if, in your assessment, certainly if there's like an immediate, this person's about to lose their home or there's some new issue that kind of arises, those might be the people that we would want to bypass the 1 month period on and fill out the form that Joseph was just showing. But I guess in my mind, I'm thinking that most of these people are not, this isn't the first time that someone in that practice will be learning that they have some of these issues, right? So that's what I'm thinking. I would think, and they may not have been addressed, but I would think that if it's a crisis,
Yeah,
some of it is
what's-
mentioned.
What's
I understand
happening
what
at
you're
our,
saying.
at our practices now, the providers are becoming, they're receiving an incentive to
For-
have their patients under case management. So where some of these things may have gone on before and case management wasn't aware, now they're all
Aware.
teams to know. And they're not just going to distinguish whether this person is in rich life or not. They're going to say, oh, this is a need. We have a case manager. We've been encouraged to use case managers. So we want this patient, this issue taken care of.
Exactly. So that's why I'm thinking for the purposes for Rich Life, I guess I'm not thinking there's going to be quite as many people who have immediate needs that you're going to uncover as soon as you're kind of assessing them. Because I think your point was an important one, that the people who are going to be willing, while they're going to have needs, the ones that are going to be willing to kind of say, yes, I'll be enrolled, they are probably not like so overwhelmed
Right.
that they can't even, function, right? They're going to be at some level, they're going to have a lot of issues, I'm sure, but they're not going to be so overwhelmed with some urgent thing that they're going to be dealing with.
But
That'd be
if
my
that,
guess.
if that does happen,
Yeah, you
it's
can
something
use
we
them.
can talk a little bit more about, being more
Right.
flexible with that. Because even 1 month is, it's a little bit, so.
But does this sound like a good idea, like for the purposes of like implementation, although the problem may not be new or is an old problem, whatever, but just to capture that first initial visit and then within that time frame, meet with your CHW, have the talk about the patient, and then sort of let them within that month's time get
Think
to
about
reach
those
out to the
resources.
patient. Yeah.
Yeah, I mean.
So for the ones that need, we want to be able to document when they're stepped up, so
Mhm.
I see.
I think if the sense is that they need
I
them,
got it.
then we need to
Okay.
know, because that's in our view for the study, right, that's a higher level of care than the care managers alone, right?
Got you.
So we just
Okay.
want to know like when that's occurring.
We're not using the CHWs as like support, well, they're like supportive staff, but it's like a step up. So
It's
it's
a
like
step
a
up in
higher
care, it is, yeah.
level
the
of care, so
interventions
it's
are
not
like-
like nurse, CNA, work together collaboratively on patient. It's
That can
more like another
happen.
level of intervention.
Yes, it is, yes, in our view, and from a standpoint of you know, from a clinical trial, which this is, it's the next level up. So,
Okay.
right, so care managers are first level. If they're having needs that can't be addressed just there, they step up. And then if they're not having, if the need, then we'll talk later about the specialist core, then that's another step up. Or it could be from care manager straight to care manager plus specialist. But that's another level up, and we need to capture that that's happened, because that tells us something different about what's going on.
Question
with
for
those
you,
people.
if we had to step up to the specialist,
Yeah.
would there be a need to get the community health worker involved in that process so that they could sort of help the care manager to sort of coordinate that like extra leg piece to ensure the patient like smoothly gets the connection to the specialist?
Yeah.
We'll talk a little bit more about what that piece of it is gonna look like.
Mhm.
But
Okay.
there's also, that's a great point, because along the way, you're making a determination on how much this patient needs. Like, and if that's something you see them needing, it might be, like we showed earlier, you can have a CHW and a specialist at one time. So we're definitely open for that. But we'll talk a little bit more about what that process would look like.
And you can
Okay.
just have a CM and a specialist
Yeah.
without the CHW.
Because it's just
Okay,
a clinical
okay.
question
Mhm.
that the
Yeah.
CHW is really not involved in.
Yeah. Because with the specialist, it's only for consultation, right? It's like very limited. Are there any face-to-face encounters with the
And
specialist?
we'll go over it in
Okay,
detail,
all right.
but there's no face-to-face between the patient and the specialist.
Okay.
So for those patients who aren't stepped up at 1 month, so you might have patients that you interact with where it's like, it's pretty straightforward, because this is a first intervention visit, so you're gonna see every patient at that first intervention. But some of these patients aren't wanting to be in they're not gonna be in care management throughout the study, they're not gonna be, you're seeing them every month or something like that. So these patients you might see once, maybe their blood pressure is now under control since we did the data pool. And so you might talk with them, and if they don't have any goals or they don't want to see a CHW, they're not going to see one. But if between that period, you know, maybe there are some other patients whose blood pressure aren't under control, but they don't voice that they want to see a CHW. You have 3 months before you can like actually step them up. So if they're still not controlled within that 3-month window, then you would step them up to the CHW. And that's not the exception, that's the 3-month itself. So we have some conditions here. So whether the blood pressure is uncontrolled or the patient continues to experience, you know, barriers to care, so some of those things you outlined in the first visit, and then you also have to make sure that the patient is going to meet with the CHW. And again, these are things that we've outlined in the actual document there that I showed you earlier. And then, so these are some of the things to identify, so that would identify that a patient. So there's some examples. So we go into detail in the document that I showed you, but this one here is like just showing like if a patient had a cardiac event within the last 12 months and they hadn't gone to their follow-up visit or gone to a specialty care visit, they might see a CHW to talk a little bit more about setting that appointment up. Or maybe they're having medication adherence problems. Maybe they're not understanding how and when to take their medications or not being able to afford medications. So these are just some examples that we've outlined. Again, we go more into it, cultural and personal beliefs. Patient does not feel that they are in immediate danger but would like additional support. And so you've made the determination that you want to step a patient up. So how do you coordinate that step up? So first, confirm the patient's willing to step up to a CHW and work with the CHW. Then you would schedule an appointment within the next 5 days to talk with the CHW to hand that patient off to the CHW. Well, it's not a handoff, but you would be giving a report about that patient. And then you would document this in it's called a care manager post-visit data form, which I'll show you here on this next page, which is on the right-hand side. This is in your binder toward the end. And then also in this other document, we outline steps on how to coordinate that step up. And that is here on the left-hand side. So following up, like that's another thing, is like if you pass off the patient to the CHW, you need to make sure that they actually see the patient. So we're asking that you follow up with the CHW to confirm that, like, were they able to connect with the patient, were they able to schedule the visit? Because sometimes it might be hard to get that going. And then to continue to discuss them at your, like when you meet with the care manager, maybe you find out if there's anything changed. Okay, so now we'll talk about the specialist. So that was everything about the CHW. So now let's talk about the specialist consultation. How do you go about getting the specialist core involved? So first I'll show you, these are all our specialists here. We included this in your binder as well. We have Dr. Miller, he focuses on hypertension. We have Dr. Ndumale, you guys met him. He gave his presentation the other day. He's with Hyperlipidemia. Dr. Referrals here, diabetes, endocrinologist. Dr. Gail Dommett, who is with our smoking cessation specialist. And we have Dr. Deidra Cruz, chronic kidney disease. And then Dr. Antoine, who's psychiatry we're using for depression. So again, we said at 1 month you can step a patient up to the specialist core if it's needed, and there are some criteria they have to meet. If the PCP agrees that the patient could use a consultation, then you could. And then the patient has, a poor disease control, maybe their blood pressure is out of control, and a community health worker isn't going to work for this patient. Could be, maybe they're not on the right regimens or they have conflicting treatment. These are all reasons why you would step up at 1 month. And then also at 3 months, so at 1 month, these patients are the ones that you're like, no matter what, like even if we give them a CHW, they're not going to be able to be controlled. They're going to have to go see the specialist. And so these are the patients you would do at 1 month. For the 3 months, you would first try out the CHW. If the CHW is not able to, their intervention is not able to bring the patient back under control, then you would step up to your specialist. And then how you would coordinate a specialist step up, you would first confirm with the PCP that they're going to allow the patient to go to this specialist core, and then you would complete the specialist referral form, which is included in the appendix, at which point you would send me an email and say, hey, we have a patient that we want to step up. You can upload that to JHBox, the specialist referral form. And then I would work on, in the background, to get that to the specialist core. We would meet on it and then give you a response. So at the end of the specialist, does anybody have, actually, I believe we have it right here.
Joe, can I just clarify, when you
Yes.
said that specialist panel consult, so it's not individual consult with the specialty, it's a panel?
Yeah, so, well, I'll let Dr. Cruz.
Yeah, no, so it would come in, I mean, you could talk certainly about the process. On the form that you'll fill out, it could be that the patient's problem that they're having, that you're seeking sort of a specialist opinion on, may be something that may cross over multiple, like different people, and so we'll handle that on our end. So if you indicate, so that's why it comes like to the group, and then we will kind of on our end, triage it and say, okay, this is the right person to answer that, and then get back to you with a response, and then Joe can kind of go through the process. So that's what we mean by the panel that you just, of people that you just saw.
Okay.
Mhm.
The only person I didn't notice on your panel, and
Mhm.
correct me if I'm
Yeah.
wrong, was like PharmD or pharmacist.
That's
Because
correct.
a lot of,
Mhm.
so, because sometimes that is the problem with different specialists and medication and or whatever.
Mhm.
You're obviously aware of that, so how are you, so if that's the problem, because I deal with that frequently, different
Mhm.
specialists ordering different things, how will you deal with that?
So we won't be ordering any medications or anything like that. So we
Make
won't be.
recommendations?
So, and honestly, we won't be making like sort of specific, like, we think this patient should be on 25 milligrams of metoprolol. Like, we won't be making that because we're not going to be seeing the patients. That piece, in terms of if there's questions about the number of medicines or interactions of the medicines that they're on, it might be, best to certainly speak with the physician about as a starting point. And if there is, if that practice does have access to a pharmacist or even that individual patient's pharmacist, that's probably gonna be the best place
Okay,
to
so
review
that's
it.
not
Because
the
we're
kind of
sitting
thing.
way, you know, we're far, far, far removed from
Okay.
their actual, like, clinical care. So I think maybe we should, you make sure you all are clear on, it's not a referral in the setting, in the context that you may be accustomed to, where it's, you're gonna send a patient and we're gonna physically see, examine, look at all the medicines, look at, you know, make changes. That's not what it's for. Think of it as a, and the physicians in your group, I'm sure would relate to it, think of it as a curbside. It's like, here is a group of people, we've got certain types of expertise. You're looking for an opinion about the next step for this person, given the problems that they have, the clinical problems that they have. But it's not you're not referring them to be seen, fully
So
evaluated.
you don't make recommendations basically?
We will make, you know, recommendations, but it won't be, like I was saying, it won't be add 25 milligrams of metoprolol. It would be something like, you know, based on what you share with us, you might consider, you know, these options, right? Depending on which one the patient is most comfortable with, the physician is most comfortable with prescribing. Here's maybe a sort of a little description about the evidence that's around this sort of recommended therapy. But it won't be like a specific, like, start this drug. Like, it won't be that type of thing.
So, and then I'll be
Yeah.
quiet, Joe. So, for example, let's say they're already seeing the specialists that are listed there. They already have a nephrologist,
Mm-hmm.
cardiologist, et cetera. I'm trying to wrap around what we would get from stepping them up to the specialist panel. Basically, if somebody's seeing these different specialists, it's not a matter they're not seeing, it's a matter of coordination sometimes. You got different people acting in different plans. So it could still be stepped up where you all would be, I guess it'd be almost like a second opinion type thing.
It could be, yeah, it could be in that sense, but think of it as again, curbside would be the best, and this happens a lot. I don't know if some of you relate to that term, but this happens a lot in hospitals. Like, for those of us that work in a hospital setting, you know, I may just be walking down the hall and I'll see my colleague who is a cardiologist, and I'll say, hey, you know, Sally, you know, you have a second? I've got this patient that's got XYZ going on. You know, what do you think? And Sally may say, oh, you should probably, you know, check this type of test on them. And if you find so-and-so, think about putting them on this drug. That's the type of thing you're going to get from us. It won't be this, like, very specific type of treatment recommendation. Now, we may be able to, you know, in a case like that, you could even comment, you know, hey, we've got this person, they're being seen by all the specialists, but there's concern that the combination of medicines, you know, there's issues or something like that. We may be able to have a suggestion around that. And that's where we as a group might talk. Like, if it's one that crosses over multiple different specialties that we're coming from, then we could comment on that collectively.
Yeah,
and we'll get to some of the examples at the end too of the types of things that would be an indication for stepping up to the specialist for.
So would that recommendation go directly to the PCP or to the case manager?
Yeah.
So that's part of the process. It would come back to you, the case manager, and then from there you would relay that information to the PCP. And that's first you're going to be asking the PCP if that's something that they're comfortable with getting. And if that's the case, then we would start that cycle, that channel of communication. So it would come through you to me and then to the core and then back to you.
So we need the PCP's approval before we ask to step up to
Yeah.
the specialist.
And so they're gonna need education on what that means, because you're gonna get a lot of different reactions.
So they're gonna think they're gonna write an order or.
Mhm.
So that is part of the provider education, they'll hear about this, correct?
It's some of the things we've talked about when we've gone to the systems and presented. So we've met with the providers aside from the staff, and that's one of the
Right.
things we've outlined.
At all sites?
Well, at Total Healthcare, I know we presented to the staff and to the providers. At JHCP, we didn't have this meeting, but we have been communicating with other folks who have been talking with frontline staff. But whether this information has completely gotten out, that's another thing that we can talk about and how we're going to approach that. So, but I'm going to write this down because
Yeah, me
these
too.
are
I
all
think that's an
stuff.
important thing to make sure that they understand. you all can be our ambassadors for that. We are not going to physically see them. We are not billing for them. We're not directly involved in their care whatsoever. If you use the term curbside, remember curbside, 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 that basically that's what it's like. Is we're providing, or second opinion, that would be the way to think of it, but not second opinion in the way that it usually is thought of,
Right.
where we physically see them. We're not gonna physically see them. We're not in here, we're not like,
You can read this.
some primary care physicians actually worry about when you send someone to a specialist, that then that patient's
Right.
gonna mostly start seeing them and not even see them anymore. It's not that at
No,
all.
my providers, I'll tell you, because I'm thinking of hypertension.
Yeah,
No, I shouldn't say many. Sometimes hypertension, the natural referral is usually to a cardiologist.
mm-hmm,
Do you know what I mean?
mm-hmm.
So you have somebody with hypertension not controlled, they're going from a cars. And so if I say, well, what about this? They're going to say, well, what? They're going to be confused. Is that going to replace? It isn't. I know it isn't. But if they don't understand that, the role of it,
Mm-hmm.
they're going to say, why do I want to do that? I'm going to send them to the cardiologist. Or they're going to say, he's already seen a cardiologist. Or they're going to say, well, then I don't. So that's the only thing. I want to make sure they have a clearer understanding
Mhm.
of what that is.
Mm-hmm. And some of it, and one of the things to keep in mind, they may get a response faster from us than the patient physically going, because it's important for some patients, and we'll talk about that in a moment, but for some patients it's going to be important for them to obviously physically go and see the specialist. But if it's just like, I wonder what drug might be the most evidence-based next thing to try for this person that I'm having trouble controlling the blood pressure on, then reaching out to us, they may hear back from us. They're going to hear back from us in just a few days, with that, as opposed to let's schedule a meeting, schedule an appointment. 3 months later, they go, they hope and wait for the report to come back.
Mm-hmm.
It takes some time. So we could actually be a bit of a bridge for those kind of patients. Yeah.
And that's one of the things too, when you look at the specialist referral form here. You read the top of it, and we have that disclaimer here. It says this report form and any recommendations provided by the specialist are to be received as suggestions and not treatment decisions. And so we're trying to make that clear with the form itself. So with this specialist referral form, you would complete, so for every patient that you decide that you wanted to step up to the specialist, you would complete this first piece, which is the health status section. And so for that, you would fill in this information. And a lot of this is already covered in the NCQA, so a lot of it would just be taking that information and putting it in here. Some of the information you might have to get from the electronic health record, but for the most part, you should already have gotten this. And then once you have that information, then you would choose the condition that you're trying to step this patient up for. So if it's for hypertension, you would complete the hypertension section of the form itself. And that is, a few questions here. If it's nephrology, there's smoking cessation. If it's multiple things, then you would fill out multiple conditions, but these are things that you would, when you send me that email, you say this is a patient, we're stepping them up for this reason, and then you just send the form. You upload the form on Box. I would have access to that form, because we wouldn't want to use email to send this information. And then, so that's the gist of this form itself. Now on the very back, there's actually the response form, and this is what the specialist core is going to actually fill out. So if it's one of the specialists on our core that fills this out, or it might be multiple that fill this out, I will get this information back to you. So I'll upload it on Box. You'll have access to it. I'll send you an email and say, hey, we got some suggestions here. And so then you'll take this form and put it into the EMR, and then also get this information back to your PCPs. And that's essentially what that looks like.
You said we would put this in the EMR. Okay.
Yeah. So, and this is not going to have any patient identifiers on it. This is one thing I want to make note of is when you send this to us, it's not going to have their name on this. You're going to have a study ID. And this is going to be especially important when you're putting this in the EMR later, that you don't put in something that's for another participant into the wrong chart. And so making sure that if you have a study ID on here and you upload it to JHBox, that later when you are going to do it, you do put that, I don't know what they call those, the labels, the patient labels, on this, and you put it into the chart, because everything has to have a little, that you make sure that those two are matching. Does that make sense? Okay. So that's the referral form.
Yeah.
And so I've outlined pretty much what this looks like in a little workflow diagram here. So if later you wanted to, I pretty much summarized it with me, like you can see my bubbles here, the little dotted ones, the circular dotted ones, and then the care manager would be the square boxes, and then, or rounded edges, and then the specialists are the square boxes here. But it pretty much outlines what the whole process would look like. So if you're, you had a question about where you were in the process, you could always look at that. We talked about the referral form.
I wanted to mention, yeah, the referral form, I can speak in, but
Yeah, I'll just
okay, so the referral form, you all have these in your binders, right?
Yes.
I think it's towards back. So, you know, we try to be, granted, they're kind of long, right? But we try to include at least the minimum amount of data, the minimum amount of questions that we thought would be important to help us have enough information to try to respond to your questions, basically, without hopefully making it too overwhelming. And you're based on what the main question is, and you can basically go to that section that is relevant to your particular patient, right? So so that's kind of how that will work. I don't know if you all have, you're skimming it over, if there's any questions that sort of jump out about it. But it's got some things around, you know, their history, but then also their past medical history, but then also some questions about the actual treatment that they're receiving currently for these conditions, the ones that you're going to be asking about. Okay. And that's the basic premise of that. So as Joe mentioned, so, you know, maintaining communication with him would be important, and then the response that comes from our group, and we're going to talk in detail about the different types of the different conditions, but the response that comes from us will then get uploaded. Let's see, the response from us back to PCP will basically get uploaded, and then we'll be sort of following up to make sure that that you received the response. And then would be asking you about whether it got supplied to the primary care provider, and were there any actions basically that were taken on as a result of the of our suggestions. Yeah, because again, you know, we won't be, it's not a mandate, but we do want to see what gets implemented. And there's no requirement that it is, but it's just we'd like to document if that is the case, right? And then, so the next piece, I think we've been doing questions all through, so okay.
Yeah,
Thank you, Joe, for your patience.
I've got a question now.
Let's say, for example, the primary care provider decides to send the patient to a nephrologist.
Sure.
Based on the lab work.
To physically send the patient to a nephrologist.
Okay.
Sure. Is that what you're referring to?
That's what I'm referring to. Would that be a step-up referral here, or would that be an adverse event to be reported? You know, let's say the lab work comes in, something's not quite right, the blood pressure's still out of control, to send the patient to a nephrologist.
So you mean totally separate from the specialist core of the study?
Correct.
Yeah, I don't know that it would be, do we consider it I don't think it's considered an adverse event, but it's just something that would be, you all would document. But that's totally, it would be an action that, you mean if they had never been stepped up to the specialist core at all,
Correct.
right?
But they're in the study.
Yeah, but they're in the
They're
study.
in the study, so how do you account for that?
If it's something new, or if this is something that's
Something
occurred
new.
prior
Something
to.
new, I'm talking about new.
If it's something new, that sounds to me like an adverse event, but it's something that I would have to clarify.
Mhm.
I'll talk a little bit, I'll write that down actually.
So your question in general, if we would apply obviously to other specialists, although I like the example of a nephrologist, that is my
Right.
favorite.
I know.
Specialist. But,
But you see how that would come up, though. Okay,
But
I
so
got
is
the
it-
lab work, and you know how the doctors are. I got the lab work, or
Uh-huh.
whatever. I'm not gonna be bothered with this. This is the doctor talking,
Mhm.
stepping it up. I'm sending him down
Mhm.
down the lane to Dr. So-and-so to get this taken care of.
Okay. So your question is referral sort of physical referral, I'll say, is physical referral to a specialist
It's still related.
on that. My general sense is that sounds like stuff is just going to happen in the process. And certainly an event where they get hospitalized
right.
or something
How do
like
you
that.
account for
That's an event we want to capture. But the actual these sort of care processes, like we referred this person to see this type of doctor. My sense is we want to capture it, but I'm not sure it'd be considered an adverse event
Right,
because that's
right.
very subjective. Because one primary care provider would refer and another would for the same thing. So I'm not sure if it's adverse. So we can circle back. Yeah,
Right.
we'd have to just sort of clarify how we want to capture those. Okay, so let's go through some of the conditions. Okay, just to be pretty specific around things. So hypertension. So as you know, the study is focused around hypertension. We do though have in our subspecialist core we have Dr. Pete Miller, who has expertise around hypertension, okay? And so here, we listed some of the indications, potential indications for referral to our subspecialist core, okay? So under that point 2 there, so if there's a possibility that the patient has an underlying secondary cause, so you all are probably familiar with essential hypertension. I think we've already had the talk, right, about this. So essential hypertension, that's going to be the one where most people who have hypertension, that's going to be the cause. But if there's some indication that they may have some other thing happening that is leading them to develop high blood pressure, those are the types of patients that at least need to have some subspecialists weigh in on, because often they require different types of evaluation and different treatment than patients with essential hypertension, right? So for that point number 2, we're showing you some examples of that. So people with these electrolyte changes, so they've got a low potassium or a low sodium, which can, low potassium and high sodium in that case when we're talking about this Con syndrome, which is a syndrome where you make too much of a hormone called aldosterone, right? So that can happen in those people. And then creatinine is high, which would obviously indicate kidney disease, and kidney disease can be both a cause and a consequence of high blood pressure, right? So it could be that the kidney disease is actually leading to the high blood pressure. So those people with other signs like proteinuria, hematuria, so protein or blood in the urine. The sudden onset or rapid, it won't be a sudden onset of high blood pressure in the case of these patients, but rapid worsening or resistant hypertension, meaning we've got them on 4 medicines or more, and their blood pressure, and we think they're taking them, because that's always an important part of it, right? And their blood pressure is still not controlled. These are people that we want for you to reach out, think about reaching out and us to weigh in and provide an opinion about this. Young people, anyone who's under the age of 40, who has, particularly has hypertension that we can't control with medicines, is someone that needs probably a specialist to weigh in on. The reason being, the rates of those conditions above that I just mentioned are much higher in young people with high blood pressure. So a young person with high blood pressure, it's unusual for them to have essential hypertension. It's often that it's because of something else, something underlying. Sometimes it hasn't even been discovered yet, but it's sometimes often from something else. So then the third point, so if you're having, therapeutic problems, like the blood pressure's bouncing all over the place, where the patient says when they're at home, the blood pressure is 100/70, and they come to you and it's 160/110, like these sort of weird things, or you see that they visited some other doctor and the blood pressure was in one place, and when they visit you, it's in another place. Those kind of things can be a reason for us to weigh in. Not tolerating certain medicines. So you mentioned that. Now we're not pharmacists, but we can help your team to think about certain combinations of medicines that might, or timing of taking certain medicines. There's some evidence around patients who take medicines in the evening, at least one medicine in the evening, have better outcomes, like survival actually, and lower rates of things like heart attacks and strokes. So things like that, like helping to think about how, the timing of the meds, right, as a suggestion. And then people who have, some patients obviously have allergies and other reasons why they can't take certain medicines. We can help you to think about other classes of medicines that might work for them. And then like either persistent non-adherence or treatment refusal, we can help with thinking about, okay, well, what can you do? Maybe that's not related to medicines. Is it a dietary approach that you might want to try? Initial involvement in the rich life, but if they were to become pregnant in the course of the study, that would be someone that we might weigh in on as far as the treatment for them during pregnancy. We do treat hypertension in pregnancy. So then urgent things, so in the red there, so urgent treatments needed, or there's like a condition, something like, pheochromocytoma, which is this condition where there's like these little masses usually in the adrenal glands that are giving off hormones causing the blood pressure to just go super sky high. People have sweating and headaches, and it's just a horrible condition. People like that, that's, you shouldn't be using, or they're having like a TIA, or they're developing, they're having like serious complications. We would not be the first folks that you should reach out to, because again, we're not seeing those people. This is going to be, follow the adverse event protocols, basically, right? For the practice that you're in, which probably involves, emergency room, right? Exactly. Hang up and dial 911, right? This is the hang up.
Folks, as I was thinking about when you were talking about the medication, what about sort of like if folks have like a pill burden and they on like 5 blood pressure medications, would it be wise to then like consult with you guys and say, hey, why don't you try these 2 that can take the place of all of that?
That would be a great indication. So like the example, the more than 4 therapeutic agents, right? Absolutely. Yeah,
Okay.
think about that. Like what would be, if we wanted to pare down, what's going to be the most evidence-based? This is the type of thing you would get back from us. What would be the most evidence-based set of medicines that you might want to pare down to? Which ones might be available in combo pills, reduce the pill burden, things of that nature, where because sometimes people just don't realize there are certain medicines whose doses can be escalated. Some providers have a tendency to add a second one before escalating the first, and so things like that we can suggest. Yeah.
Because I've seen some little old ladies on like 5 different blood pressure medications, and I'm like, oh, come on, like why are you on 5 different blood pressure medications? Like, if you add 2 or take away 1, but something out there should help to reduce the amount of blood pressure pills, because I feel like it's a risk too for like low blood pressure events and falls.
No, absolutely. That would be
I would
absolutely. So taking too many pills. Can you suggest, how we might pare down? Absolutely. That would be the
So
type
that
of thing.
report would be given to the provider?
Yeah, well, we would fill out this form. You have your question on there, and then, you send it over as we just talked about. It would come through Joe, and then he'd bring it to our group, and then we would send back the suggestions, right?
Nice response form.
The response, yeah.
And you can see those different things, impressions, recommendations, and then other pertinent information. And it might be that I ask for more information if they requested it, so there might be a little open channel there.
Now, are the identities of the panel, will that be addressed on the form?
I can understand about what
the
you guys
doctor.
mean by panel, because say for instance, so this form will sort of lead you guys, I think, into saying whether or not if it's a panel or not, because if there's multiple problems like depression, they got problems with their kidneys, they got blood pressure problems, you would fill all of that out.
We all need to talk, then if it's a bunch of us, then we all need to talk.
And that would warrant like a panel conversation.
Yeah, multiple, it could be something that crosses over into multiple.
But if it's just
one thing.
it's just
So
somebody
it
from
would,
the
it would be, like in your case, if you responded to that, you just say what your specialty is, so the doctor would know. This, you know what I mean, the credentials of the person
Oh, sure,
responding.
yeah, sure. And I think we would, in our communication with them, let them know, do we indicate that on there? We would kind of let them know, right here.
Would you get
Responding clinician and qualifications. That's one of the line items, yeah.
Okay, good.
What's
Because
that?
a lot of times community providers just don't have that latest evidence-based research
that's
about
Yeah, that's
stuff.
And that's
Right,
why
they're
I
not coming
said,
to these trainings, they just
Yeah,
sort of
that's fine.
Go
Um,
right,
for what they know, and then
that's why that
Patients over
credentialing is
20
important,
medications.
because then the doctor will look at it and say, oh, okay, yeah, they should know.
Yeah, well, we
Most
hope
likely
so.
so.
Yeah, we hope that would be, I mean, I can tell you, like Dr. Miller is a actually internationally renowned expert in hypertension. So he's not he knows hypertension. So it should go over fine, around that. But hopefully they would be comfortable with that. in terms of, you know, if we kind of say who we are. And it is, you know, obviously we work at a university in an academic setting, so we're both generally up on latest things, but we also generate a lot of the latest things, right? So hopefully they will believe our
I asked that, like,
suggestion.
we have, you know, when we do the clinical rounds of behavioral health, I've taken some recommendations back to the doctors, and the doctors will say, well, who is this? And I'll say, oh, it's Dr. Damien, such and such, and they're, oh, okay. And they're more apt to listen
Yeah.
and to follow.
Were the,
I mean,
the
how
physicians,
much, I'm sorry, go ahead.
were the physicians at the groups that you already talked to, were they explained about the step up to the specialist,
We
and
did.
who the specialists were?
Yeah, we didn't talk about who was on the panel and like specifically name them, but we talked about the intervention itself.
And will that be done with JHCP providers as well?
We'll talk a little bit more about what that's gonna look like, but I'm hoping that we do, like, if not, sending out a mass email with more information about that. But there was an email sent out, so it's kind
They
of
don't
like.
listen to emails.
They may
so
not, they may
don't.
not read
But
the
as
emails.
far
This may be something we'd wanna arm the care managers with, like a little,
Yeah.
you know,
If we.
That's
here's
what
what we
I was
are, yeah.
Yeah, I feel like this sort of program gives us some sort of autonomy to be able to make a call to say, like, speak to your provider and just say, hey, this patient has been dealing with X, Y, and Z for a long time, and we have a specialist that I could sort of collect patient information on and then give to the specialist for a review of this particular problem. Are you on board? Right? And like putting it like that should just let the provider let you go ahead on about your business and do what you gotta do. You know what I'm saying?
But we certainly do need their buy-in, right?
Right,
Because if
right.
any change is gonna happen in terms of the management, they have to be the ones that make
Right.
it. So I think it's important, and there are,
I can provide you
You know.
with this contact sheet,
Mhm.
if that's
Yeah.
something you'd be interested in, so that when you
Yeah.
do make the recommendation, you could actually, it has all their credentials, who they are, a little short bio.
That would be good.
Yeah,
That way
That
you
would be
can like
good.
slide that and say, these are the folks that'll be reviewing this case, and so it'll give a little more of that
But I
bio.
think the buy-in from, at least from our site, I think the buy-in's gonna be better if it comes from somebody higher up than me.
Right, right, they see the
That
credentials.
says, this is the program, this is what it looks like, and these are the things that you're gonna be able to do with it.
So if you guys approach
mhm,
the
mhm.
practice with that, and
Okay.
and we support it with this
Yeah.
documentation. After a while, they'll become familiar with it,
Yeah.
and they'll say, oh, yeah, okay, fine.
Go ahead,
Yeah,
especially,
okay.
yeah.
yeah, and I think this is all really valuable, sort of insights into
We
this,
just
and I
know
think
our-
it's,
we just know our doctors.
you know how, yeah, you know how it
Yeah.
works, and we hope that it's like, I mean, I know I appreciate having people that I can kind of curbside and just say, hey, you know, what do you think about this? And we hope that we can provide that service, you know, really, in the context of the study. So that's the goal of it. Yeah, so let's go, so there's hypertension, we also need to have that. So let's talk about some of the other specialties. So, endocrinologists, so our division director, our head endocrinologist at Johns Hopkins Medicine is the specialist leader here, okay? Expert in diabetes in particular, right? So, it is, so some of the indications for referral, so it would be, you know, an A1C that's kind of close to range where we'd like it, but their individualized goals haven't been met through this sort of intensive treatment after about 6 months. So, or someone who has, and of course the goal is to have an A1C less than 7, right? So A1C greater than 8 for more than 6 months, or any A1C that's 1.4 times the upper limit of normal. So it's basically high. That A1C is high, right? Like well above 8. And it's been a while. It's been like more than 6 months. Then that would be a reason to sort of think about, well, what is it that we might change that might help this patient? So severe or recurrent hypoglycemia, right? So people with the 70 milligrams or less, 70 or less for blood sugar. If there's a consideration of starting insulin pump therapy, that would be a reason to have some weigh-in from our group. Management of an insulin regimen that's already requiring multiple daily injections, because again, we would be able to help think about how to streamline that for the patient. If continuous glucose monitoring is something that you all are pursuing in order to either to try to understand what's happening in terms of the patient's fluctuations in sugars, and then management of other types of diabetes like type 1 or post-organ transplant diabetes. So these are, so type 1, obviously, the overwhelming majority of patients with diabetes in the United States have type 2 diabetes, right, which is going to be the bulk of what you already see and what you're going to see in this study. But for people with type 1, we may manage it a little bit differently because they're going to be insulin dependent. And then the post-organ transplant patients also can be kind of unique.
Dr. I'm sorry, I'm still trying to wrap my head about something. So for example, your example of their initiation and or management of insulin pump therapy.
Sure.
If my PCP was going to initiate insulin pump therapy, they absolutely would send them to an endocrinologist. They're not going to do that.
Sure.
So, but you're saying I would also refer them to you all.
You wouldn't have, this could be an indication. That's fine if they want to send them. Here's the type of question that you could send. This, you could say, this is someone we are thinking may need, who may be a good candidate for insulin pump therapy, right? You could reach out to our specialist court and say, what do you agree? Is there something about their history that sounds like they wouldn't be a good candidate for it? And so the types of things that we would be asking for, and again, I'm no endocrinologist, but are things like, well, what type of, how does their blood sugar range during the day? How frequently they're having episodes of hypoglycemia, things like that, that would cue us in to say, okay, well, maybe this is someone who needs a pump, right? And maybe may make recommendations about the settings or something for that pump, for when they do get it, right? So you could think about it, so obviously the prescription for it probably should come from an endocrinologist.
Yeah, our PCPs would not.
Right,
deal with
and I
this.
don't think most do. But as far as, like, say, if it was just a question of whether this is a good candidate for a pump, then that would be the type of thing you might think about reaching out to us for. And again, we were probably going to respond to you faster than that endocrinology appointment. Yeah, you had to remind that about the timing then? Yeah.
Well, it's quicker, like you're saying.
Yeah.
It's a quick.
Just a quick question about, is this a good candidate for it? You'd probably want us to weigh in maybe even before you send them, because why send them to go to an appointment for them to say, this isn't a good candidate for a pump, right? If that's your question to a person that they're going to physically go see, are they a good candidate for a pump? That's kind of something you can almost glean just from the history and okay. Right? So if you think of it in that way. So my favorite subject, so indications for referrals from nephrologists. So if a patient has an acute or sort of subacute, like, over several months, increase in their creatinine, or, what would come along with it would be a fall in their glomerular filtration rate, which is reported now on really all lab, in all lab reports, and that would be an indication to reach out to us. If their glomerular filtration rate is under 30, it's actually indicated in our guidelines that patients at that level should be physically followed by a nephrologist. And so this would absolutely be someone that you might reach out to us and say, hey, what do you think? And we'd probably come back and say, yeah, this is somebody that probably should be being seen by someone. Because those patients, we want to, start to prepare them for what may ultimately end up being a need for transplant or need for dialysis, right? So if they have, an estimated GFR under 60, which is considered abnormal, right, and would be an indication of chronic kidney disease in a young patient, okay, so someone who's under 40. Again, here, because these are patients that often have diseases that progress rapidly, okay, so things like lupus nephritis or diabetic nephropathy that can progress very quickly, or some other conditions. And so we want to see them we want to know about them. You can reach out to us and we can kind of give you a sense of, like, maybe as you're thinking about referring them to a nephrologist that would see them physically, what type of testing you'd want to already have done before they go, things like that. If there's any uncertain etiology of a patient with who has kidney disease, you don't understand what the kidney disease is from, happy to sort of provide some thoughts on that. If there's anemia in the setting of kidney disease, we can offer comments about that. Difficulty managing electrolyte problems, difficulties with bone or mineral disease, so if their potassium or phosphorus is high, or calcium is low, things like that, we can offer some comments on that. Again, just keeping in mind, it's all gonna be suggestions, so that let your providers know we're not writing prescriptions, it's not, nor is it prescriptive, where we're saying do this. It's gonna be, these are the things that you can consider doing, right? So that's the kidney part. And then other things, so other lab indications that you may find that would be an indication, so if they have proteinuria, so particularly quite high and persistent amounts of proteinuria, progressive albuminuria, which is another kind of basically type of proteinuria. If they've got blood in their urine that's not explained by other things, we could weigh in. Hypertension, so we actually, it's funny you said cardiologists, which is interesting. I think for hypertension, some people send their patients to cardiologists, some people send their patients to nephrologists. It's at least an argument that's at least 100 years old about who the most appropriate person is. We think of the kidney as sort of the master of blood pressure regulation, so we also are hypertension. We have expertise around hypertension as well. So that can, again, this is why when we say you send it to the whole group, because for myself and then Dr. Miller, we'll probably discuss, particularly if the patient's got both kidney disease and we know everybody's going to have high blood pressure because they're in rich life, right? Then we're thinking about we're going to think about what's the best drug for this person given that they've got kidney disease and they have hypertension, right? Which things are likely to work. And then recurrent or extensive kidney stones. You're probably going to have some patients with kidney stones. We can weigh in there, and then hereditary forms of kidney disease. If there's any question about like, oh, this person says they've got stuff running in their family, what should we do about that? Questions about the nephrology piece of things? You all have a lot of patients with kidney disease in your practice? I'm sure you do. So, and this is an area, I think, for the other specialists, I think we certainly in nephrology we get a fair amount of referrals. For some of the others, because there's not, sometimes primary care providers have questions about what the nephrologist does, like short of, if it's a patient who's almost at the point of needing dialysis, they're clear on what we do. Sometimes they're not as clear on what we can actually do. And so there may be even more questions here about people with less severe disease and whether it makes sense to reach out to us about that, right? So sometimes a lot of primary care providers are like, oh, well, we're managing their high blood pressure and their diabetes, why do we need a kidney specialist to weigh in?
I find at my site the opposite. Any abnormal blood work, boom, refer to Referrals.
They call, okay.
I mean, they refer at the slightest from any referral. Well, no, the reason I'm saying
They
this
get
is
nervous, okay.
probably because they can handle primary problems and they don't have time to handle these others and the testing and so forth, so they just refer them all out. So that's why I'm in my mind trying to picture them agreeing for me to send this to a specialist and go, I've already referred them, I'm already referring them to him. So I'm listening and I'm trying to understand.
That's interesting. So you might, so again, I think this is where we may help, one, to get a response sooner, and may even enhance the quality of that physical referral that they get. And here's what I mean by that. By reaching out to us first, when we can probably make a recommendation around like what tests are needed, or should be considered prior to them even seeing someone, so that then when they go, it's a richer appointment, and they can get more done, in that appointment. So I think that's something that I would pitch to them, to your providers that you're working with, is that we might help to set up that referral that's going to happen in a way that's going to be more informative for the receiving nephrologist. And sometimes it really is, I mean, like you're saying they refer everybody, right?
They do.
We might be able to help reduce that in terms of the number that are physically seen, because some people, we get patients in our clinic who they come to see us and we're like, you don't have to come back for another year or at all, and so sometimes there are things that can be handled just from like a little bit of advice that don't necessarily require a face-to-face visit. So we might be able to actually help with that. They may be very appreciative of the opportunity to have this
Somebody in
sort of,
between.
to have somebody in between.
Compare this to the 1 month step up for the specialist. I'm confused.
So it's possible, and Joe, you can weigh in, that similar to with the CHW, you could have a person who in that first month, right, of you managing them, we could use a specialist to weigh in. Similar to what we said you could do you could put in a request for this early step up, right?
So
to
there's,
CHW.
yeah, so there's gonna be patients where you might already think, like,
Mhm.
there could be a medication adherence issue here, and you might choose to use the CHW to try to address that. And it might be that 3 months go by after the CHW, they've been stepped up to a CHW, that you say, okay, they're still not controlled. It could be a behavior health thing, it could be maybe other issues that you would then go to the specialist themselves, at which point it wouldn't be that immediate 1 month step up. There are some patients that you would have that you might already be thinking they've been in care management for a while, they've already been seeing somebody like maybe a CHW, and they could use a specialist now, and so you might make that 1 month step up instead of waiting the full 3 months. And so we're leaving that part of that decision making up to you, and we give a lot of examples there for you to work off of. But does that answer?
Yeah, are they gonna, I was under the understanding, maybe I was mistaken, that they will not be enrolling patients in the study that are currently in case management.
So there's going to be patients within these different sites that so at JHCP, they have care managers at some sites, but not all sites, or at all sites? Like, how does that
Well, we
work?
have all sites covered, they might not
By
be
care
embedded.
I'm
Okay.
embedded, somebody else
I'm
might be
embedded,
dedicated.
Okay.
she's dedicated, she
Okay.
goes to a couple sites.
Okay, but and what about community health workers?
Same thing, they're assigned, to cover.
There is availability for community health workers everywhere now, but we
Okay.
just, in Western Maryland, just got access to them
Yeah,
not too
but
long
in
ago.
thinking about our inclusion criteria, you're right. So they couldn't have been involved in care management. But you're going to be making the determination that if you see that there's possibly a social need there that you could meet through the CHW, that's what I'm thinking. Like, you could probably address it by stepping them up to a CHW prior to even thinking about going to a specialist. And so that's how we're thinking you make the determination first, the CHW, and then later the specialist, at which month it would be specialist after you've tried the CHW for 3 months. Does that make sense?
But the specialist is.
You can go directly to specialists, though.
Yeah,
That was the
yeah, you
question.
could have
Specialist
both.
is more like health problem focused, whereas the CHW
Just social.
could be like social,
Yeah.
is how you could sort of
And
break it up.
we do have behavioral health.
Social and behavioral, I would
Yeah,
say for the CHWs, because it could be like medication adherence, right? That's medical,
Yeah.
but it's more of it's a behavioral kind of thing.
But if something is really, if we are just picking them up and, say they've had a history of 3 kidney stones in the past 6 months, can we immediately, within the first month, send them, do the specialty step up?
I would hate to answer this wrong, but it depends on what goals I would think that it would depend on some of the goals that you're setting with that patient. And when it comes to kidney stones, I'm not sure that that's more medical related outside of setting goals with the patient about you can't control that. We're talking more blood pressure here and
Or
like
like
things like
syncopal episodes,
Yeah.
like patient has reported having
Yeah, you can
multiple
control.
episodes of syncope where
You
they
certainly,
just feel faintish and
Right.
black out, but they've never been referred to like a cardiologist or some other place to sort of talk about that, so that weird event could say, okay, maybe let's see what a specialist could say about why this, like what could be contributing to the patient's syncope, like weird stuff like that.
well, it would, so to your point, Joe, and you actually can control kidney stones, by the way, so it does, to your point about the goals, right? So I wouldn't like think of it in this way, like you've got this patient that you do the intake and they've got like 10 medical problems. And you look and you see like on that list, there's this thing that happens to be one of the things that I've gone over. And you say, oh, okay, well maybe we'll reach out to the specialist for it. I would think of it a little bit differently, like if there's something that it really is a focus of their care, like, okay, we're having to escalate medicines for this condition because it's out of control. Or or the patient comes in, every week saying, oh my God, I'm having kidney stones, Like I wouldn't necessarily reach out to us early, like within that first month, on the grounds of they've got a history of stones. But if it's like, oh, they keep coming in, it's a recurring episode, right? And so it's a problem right now that the patient wants to deal with because they're having a lot of problems around it. Then that's the type of thing that would be it's a reason for us to get engaged, earlier. But I think because they've got so many, they're gonna have long problem lists. So I would think about it as being like the things that are at the top of that, at the top of the list of concerns, or that particularly if you're thinking about an early step up, like one that's within a month, that it would be, okay, well, what's the thing that's really in the way, that's their problem that they're dealing with right now. Yeah. Does that make sense?
Mm-hmm.
So think about it in terms of more of an urgent concern. Oh.
Sorry, wait.
Oh, okay.
I'll be right back. That's my meter. I paid,
Oh, your meter?
so-
Okay.
Yeah, I don't want to check it.
Do you need coins?
No,
Are you good?
I have
Okay.
my wallet. I just gotta run it up.
Okay, so cardiologist. So we have, Dr. Chiatti and Dumoulin, who you all met. So he's one of our faculty in cardiology. He does, his research work is around congestive heart failure in specific, right? So he has a lot of expertise around that. So these are some of the indications. So in the absence of current care by a cardiologist, right? So here, he sort of made that distinction. If they have a presence of a new diagnosis or high suspicion of coronary heart disease, congestive heart failure, cardiomyopathy, or moderate or severe valvular heart disease. They've got an arrhythmia, like those listed there. Those would be people that we would suggest you all reach out to us on, okay? Then in most cases, if we know that they have those problems, they've already been seen, they've already been referred and maybe already seen by a cardiologist. But if it's a sort of a new problem, reach out to us. We're probably going to be able to see them, we're probably going to be able to respond to you quicker than they're going to be able to get into a cardiology appointment. So those are reasons to kind of reach out to us. So unstable coronary heart disease, so meaning either new, like unstable angina, new or increasing chest pain that suggested that they may have ischemia, or persistent ischemic symptoms of concern to the providers that despite them being on therapy, right, these would be people that you could reach out and we could offer some thoughts on an approach to trying to deal with that. And the final thing, so unstable or decompensated heart failure, like they've newly started having shortness of breath when they're resting, they're getting shortness of breath at night, they're having shortness of breath with minimal activity, or they're having like increasing heart failure symptoms. Again, these would be patients that we'd want to hear about, and I don't know if there's more on the next, a little bit more. There's a little bit more. So again, worsening other symptoms, depression, shortness of breath, edema, ascites, so it's a fluid in the belly, despite your current therapy. Evidence for unstable arrhythmias, like them having palpitations, lightheadedness, other symptoms despite being on therapy. Any concerning change in the pattern of what was previously stable cardiovascular symptoms would be a reason to reach out to us. And then, or people who are at high risk for developing cardiovascular disease, like if you were to do their Framingham risk score and they're above 20%. So you plug in factors like their cholesterol and other things to calculate their risk. These would be people that we might make some suggestions around, like, oh, this is someone who maybe they need an aspirin, or maybe they need a weight loss regimen, or maybe they need some things to help mitigate the risk. And then, so people like who have conditions like familial hypercholesterolemia, who have very high risk of heart disease, we could certainly provide some suggestions around. So I'm sure with that, so heart disease is obviously in many cases it can be very emergent, like those sort of things that people are presenting with. And I'm sure you all you can distinguish between like someone who is acutely having an episode of chest pain, we need to call 911, right? Versus these are people who in many cases will have a diagnosis of heart disease and maybe their symptoms are worsening, or maybe they're having more swelling in their legs, or getting a little bit more pain, but it's not like so acute that you feel like they need to go to the emergency room. These are people that we may be able to make some suggestions around. So what's your experience around with the cardiologist? Do you all refer a lot to cardiology? Yeah. And is it mostly what's your sense of, is it mostly like people with really severe problems, or is it just for
Yeah.
blood pressure, like
Or
is it?
folks who have cardiomyopathies, so.
Okay.
If they have cardiomyopathies, if they have, congestive heart failure,
Yeah.
I think a
based
lot of
upon the
hours.
patient's assessment, if something's weird about the assessment. I know one patient, I don't know if it was the EKG or something about the patient's cardio assessment that made the provider refer the patient to cardiology, and then we discovered that the patient had an aortic abdominal aneurysm.
Mm-hmm.
And that patient was like, had poor follow-up with the cardiologist too after we found that out.
Well, they need to see a vascular
So-
surgeon at that point anyway, so.
Yeah, so we referred them to the cardiologist. Cardiologist didn't think that it was bad enough at that point to go to surgery, but just required more follow-up with cardiology.
I think a lot of our patients that I think of that are active with cardiology, they've had some sort of an emergent episode, and they've had a connection there, and then they've come back to us, you know, from hospital, ER, or whatever, and then we pursue, you know, have them continue with them.
Continue with it, and I think similar to the point I was making earlier about nephrology, I think the opportunity here is that, most cardiologists, particularly patients like that, they're seeing them maybe every 6 months to a year, right? I think this is an opportunity here for just like, you know, minor tweaks that that the providers may be kind of thinking about and might want an opinion about, you know, I think is where we would be able to weigh in there. Because I know it can be hard to get the patients physically, and even if they're followed by somebody, it could get, you know, they've got a change in their status, but it's still hard to get them in just to be seen soon, you know, or even, you know, even within a month or two, sometimes it can be difficult depending on the
I know for
setting, so.
me, what I plan on doing, like, while thinking about this is reviewing the patient's, like, last note, or like, next to last note, or like, whatever time they were last seen, and just sort of looking at what the problems were that were picked up in the patient's assessment and visit with the provider. If there's anything that involves one of those systems that we can step up, whether if the provider says patient creatinine was elevated, but we'll have patient come back in 3 months or something. So something like that, I would sort of maybe consider stepping up.
Yeah, and I think that would be, it's gonna be your opportunity to kind of suggest that, you know, to the provider, say, look, we have this resource, you know, you're looking to watch, you know, would you like to get another,
Versus
get an
trying
opinion?
to make a decision on my own. I think that's a win with the providers too, like if you sort of review their notes and then pick out something that they themselves wrote as like a problem. And then bring that back and say, hey, I noticed that you want to bring the patient back in 3 months to sort of follow up on this, but we could also have like somebody, like a specialist, look at this too, to weigh in on it.
Yeah.
I think
that's a
for
good,
me,
really
I think
good way.
that's-
No, I think that's a good way to think about it. Just, you may have to remind them maybe frequently until they get kind of used to things, that this is a resource that they can tap into. Okay. So depression. So we have, Dr. Dennis Antoine, who is one of our psychiatrists here at Hopkins and has expertise around depression. So he'll be heading up this core. So indications for reaching out to us here. So it's going to be a patient that's suffering from psychotic symptoms. So this is getting into the urgent space. Patient has a history of bipolar disorder, and maybe you're trying to also, obviously you're also going to be trying to manage their high blood pressure and other health conditions, but may need help with thinking about, like, in the context of that, how do we manage their bipolar disorder, right? There's a risk of suicide based on either current suicidal ideation or personal and family history of previous suicide attempt. The primary care provider just doesn't feel sufficiently experienced to manage their depression, which I think they're in a lot of primary care practices, we're now screening patients for depression, but not everyone is comfortable treating it, right? Think about especially in the older adults. Yeah, so there's a question about that. Medications, concerns about the kind of the multiple medications, lots of polypharmacy, as it's called, right? So there's that concern. And then if the diagnosis isn't clear, like this diagnosis of depression or their mental health condition, it's just not clear what's really happening. If the patient has more than one psychiatric disorder, if there have been 2 or more attempts to treat their depressive disorder that have failed or resulted only in a partial response. And these are people we could reach out to about, or if the patient's had side effects or contraindications to, or has contraindications to several of the first-line medications. If there is some challenges even in the relationship, so that this happens a lot in psychiatry, right? So and can happen in primary care as well, where the treatment of that patient's condition becomes challenged because of just relational issues, like the patient gets angry with the provider just is frustrated with the patient. Even this is something that we could offer some suggestions around, or it can happen with you all too, with the care managers too, with these patients. If there's non-adherence to antidepressant medication, if non-adherence is suspected to their antidepressant medications, these are some of the things that we could sort of provide some insights on. Some of them can be measured. Some of the drugs can be measured in the urine, for example, so we could actually check to see, does it look like this person's taking it? Things like that can be done depending on what the drug is. So that's depression. So any comments or questions about that?
So, with access to mental health being one of our challenges, would your panel have, let's say, special insights to getting people into certain programs, or
Say Meg.
kind of get stepped up? Like I've had a couple people that have been trying to get into the Johns Hopkins program. They didn't work out. It was a long wait. So if I had a patient like that, it's geriatrics, primary care provider wasn't comfortable in giving them more than the Zoloft that they were on, we were spinning for a while. So if I present something like that to the panel, would they be able to say, okay, try this medication, but also I have insight to kind of bump you up on that list to get you into.
So that, I'm not sure we would be able to do sort of that.
That would be nice, right?
Because that would be really nice. Yeah, so I'm not sure that we'll be able, because again, we won't know the patient's name, so we're going to be, they're going to come over to us on a form with a study ID number on it. We won't know the patient's names, and we won't be getting, that's getting involved in their care.
Okay.
So it's making a phone call and saying, this person, so-and-so, needs to be in this clinic. What we might be able to do, though, is to suggest programs that you could contact that we may have knowledge of them being willing to take a patient like yours, right? But we won't be able to do the
Push.
I need you to see so-and-so next week. Like, we probably can't do that. Sorry.
I tried.
It was a valiant effort, valiant and admirable effort.
Because that one, seriously, that psychiatric and the compliance with medications and the other issues of depression, get that a lot.
Yeah, I'm sure you do.
I get that a lot.
I'm sure you get a ton. I'm sure you get a ton. Yeah, I'm sure you get a ton.
I'm wondering though, like if he would, wow, because it takes a long time to get in the psych too, especially outpatient psych, and to get with the psychiatrist for medication management for depression or something like that. So I'm wondering if maybe he could give like a small recommendation that a primary care provider could like easily start. As far as like an antidepressant, anti-anxiety.
I think so.
That could be managed sort of in a clinic base while you're waiting.
I think so, and I think that you would frame it into that question, like we're looking, having trouble getting into community psychiatry, what would be a recommended first line therapy, for someone with these other health problems at this age, so on and so forth. Sure. That would be the type of thing, we do that in nephrology, like, you're having trouble, okay, well, you start this drug, check it, think about starting this drug again. It's going to be suggestions. Check their blood work a week later, if everything was okay, continue it, that kind of thing. Like we would suggest those sort of things. Yeah, we do that on the psychiatry side as well. Yeah,
that'd be good.
So tobacco cessation. So Dr. Gail Dommett is leading this piece. So she's a general internist. What she studies is she haven't spoken to him, right? I don't think so.
We had tobacco cessation yesterday.
Oh, you did, but it wasn't
Her
she.
program manager.
Did it, okay, did the presentation. So what Dr. Donna does, Dr. Donna studies, her work is in patients with serious mental illness, so like schizophrenia, bipolar disorder, and for those, with those individuals, developing ways to help them make lifestyle changes like quitting smoking, losing weight, right? So in a population that a lot of people would say it's very difficult probably to get them to change a health habit, she's actually been very successful in that. So she has a lot of expertise around this particular topic. In fact, most of her work has been around smoking cessation. So anyway, she's our specialist for this. So basically the indications here, these are going to be, all smokers really should be offered ongoing support, but some of them may need additional behavioral therapy. And so if the three things that we have listed here, if a patient has not quit by a quit date and is on pharmacotherapy for that, right? If a patient reports problems or intolerance with the pharmacologic treatment for smoking cessation, or if the patient relapses after having quit for a period, and there's suggestions that are needed around that, right? And I would add to that, if certainly after trying these things with the pharmacologic therapies, if there's any questions about, well, what's an alternative, or even getting started with one, it's like, well, they had a quit date, it's another type of question, I guess. The person is interested in quitting, but we have questions about the safety of a certain medicine for them, given their other health conditions or something like that. I think we would be able to accommodate that type of question as well. Okay, but wanting to certainly support this important piece of promoting health for the Bursite patients. And so the final thing, hyperlipidemia. So these questions would also go to Dr. Dumoulin, because it falls under the space of cardiology. It's in our mind here. So these are some specific goals. So if their LDL goal isn't at their target for them after 12 weeks, or the patient is on like near or close to near maximum dose of their statin that they're on, if they haven't tolerated the medicine or such as having problems with their liver blood tests going up or having muscle aches and things, and you're looking for, or your provider's looking for a suggestion for another medicine that might work better for them, or if there's concern for this familial type of high cholesterol that we alluded to a few moments ago, or they've had a personal history of a premature coronary heart disease, so that's under 50, right? If they've had, actually considered under 55 or under 60, sorry, for women, it's under 60. So then that might be someone that we could weigh in on as far as their cholesterol control. Okay. So those are some of your. I think that's the last questions. We've been asking questions all along, right?
Yeah.
Like, I'm just
Okay,
curious,
Frank.
like, asking you all, like, how do you all, like, connect people with resources? You guys, that's what you specialize in, is like getting people the resources they need. I'm just thinking, having this specialist core, aside from what you already do, how do you see it as being something that's beneficial to your current practice? I'm just curious, I want to hear your response. Is this a resource you would say, wow, like we have 6 specialists here who are sitting behind a table and can take this patient? How do you see that as being beneficial or maybe not beneficial, or just curious?
I think that for me, the primary benefit would be the speed.
The speed would be the benefit.
And sometimes they do sometimes the providers will say they just would like to bounce something off of somebody.
Exactly.
Mhm.
That's the
You know,
first
like
step,
they'll
yeah.
say, with diabetes, they'll be like, Dr. Janice will say, I probably should be switching him to U500, but I'm not comfortable with that. And, if she had an input from somebody, she could do it immediately, and then you could hook up with somebody locally. And we're like you, our practice is like you, they do all kinds of referrals, but, we might give them 5 referrals, and I have one guy that, a year later, he hasn't been to 1 of 5,
That's the other thing, I think in this
There's always an
population,
excuse.
well, I think in this population that which is really the focus of our study, right? Many of them face a number of challenges, both externally presented as well as internally, right? That keep them from attending a lot of these appointments. And so, you know, hopefully the benefit of them being able to get the benefit of a specialist without physically having to go, at least getting some of the benefit, I think hopefully will be helpful. What other things are you thinking?
Only thing I'm really concerned with the timelines for the step up. Because doing case management, you know, just like if you get a new patient, you're gonna go back and look at the past labs, you're gonna kind of see if they've had a problem, and you identify something. Let's say somebody has a non-compliance issue, they have high blood pressure, and they have a diagnosis of depression, but I have to wait 3 months before I set the 3-month step up. That's the only thing I have a concern with is if you already see a problem and a pattern already in place, waiting for 3 months.
So
So you can already go back, because I mean, I review the charts when I see the patient, see what the history is. So if I already see this has happened before the study, and now that they're enrolled in the study, I have to wait 3 months before I can say this person needs a psychiatrist or maybe a recommendation for.
And that's where we
anxiety.
built
That's-
in that.
That's my only. I would definitely use the referral.
That's where we built in that 1 month. Where we're giving you the opportunity to think about those things. And if this is something that you see warrants earlier intervention from a specialist, that's where that 1 month steps in. And you might even be asking, like, 1 month is still a little ways out. But that's something that we can bring back to the group and talk to them about, but it sounded like you already have patients in mind that you could benefit from.
If they run this program, yes, I have
using
quite a
this
few
core.
names are already attached, and I would.
But Gloria, let me ask you this, if you get one of these patients, and you during your assessment, they definitely have a need for behavioral health, you're going to send them to behavioral health.
Right.
It doesn't matter, you're not gonna wait
Right, that's
for
what I'm
referrals.
saying, right,
No, but you're not gonna send it to them.
No.
You're gonna send this patient right away to see a psychiatrist.
right, but sometimes with the problems with mental health, okay, I can send them to a psychiatrist, they might not be seen for another 2 months.
Yeah.
That's my issue, at least in the area
Yeah, I
that
can
I
get
serve.
patients in with therapists, but if we want somebody that's gonna prescribe, usually it's 3 to 6 months.
Right, 3 to 6
And
months.
some places won't even give me a guarantee of 6 months. That's why
Right.
I don't even know if it would be worthwhile for the specialists in the program to suggest meds, because our guys don't wanna order the
No,
meds
they
because
don't.
they're gonna have to order them forever
Mhm.
if we don't get them in a
Yes, some
program.
providers do say that.
Are they uncomfortable with ordering them for others?
Especially if they're, you know, if they're on multiple, if they need like multiple meds.
For like depression?
For depression.
Or
they're
other
very
mental
comfortable,
health.
I
Yeah, usually a med for depression is one thing.
Well, I think that would be the main, I don't think we would be making too many recommendations on like schizophrenia or, you know, in
Yeah.
terms of treatment,
So we're
so.
talking about patients that are on, you know, 3 or 4 or
I'm
5
thinking
different
about bipolar and
Yeah.
mental problems
Yeah.
for the elderly, they have to wait, so when I see that, they have to wait. Yeah, I'm gonna do the referral, but before they're actually seen, it's a long time. I actually go through JH Behavioral Health, have them do a search, I did a search according to the line of business, you know, it's, with the elderly especially, sometimes it takes a long time for them to get an appointment. They can get a therapist, but getting a psychiatrist for medication management, that's the delay. I
Okay.
can get them into counseling, but getting them to see a psychiatrist, that's where time.
It might be the practices too, like we have practices located in different areas throughout the city, and I'm thinking that maybe in some areas there may be greater need than others at this point in time. But not to say that for each of these patients, I was just thinking more the resources available to you in those specific areas. So I don't know if that plays into it at all, but.
Well, I have patients that are willing because the patients themselves have usually been looking on their own in addition to me. I have some where the spouse is looking, I'm looking, and it's taking you know, some time, and I get on the clinical rounds with Dr. Damien, and I had, I think you may have heard the last call that I called, I had referred a patient to a place, and it's highly recommended by Johns Hopkins, but it's sort of set, and I think it has to do with the clerical thing. once I made that call, we were able to push one of my patients through to be seen next week. The other one hasn't. So getting that appointment, I mean, we've been going around about for 6 months trying different places, including Johns Hopkins. So
To get them in there. So I think this is also gonna be a place where, you would certainly talk with the provider and see whether they think, as you're thinking about, is this someone that we need to reach out to our specialist core early on, see if they think so. And it's a lot is gonna depend on their comfort level with that person going untreated, undiagnosed, for the number of months that it may take before they get that appointment to.
They will give them a minimal amount just to sort of, I guess,
Well, that's what I was
take the
gonna
edge
say.
In terms of
off.
med?
I'm thinking of
Meds,
this
they'll
as
give them a little
depression.
bit, but
Yeah.
not.
Most PCPs will treat just depression.
Yeah, I think that's mostly what we're gonna be providing, at least that's the plan, that's what, that's what was listed in terms of for the specialist core. I don't think we see ourselves as treating, serious mental illness, like, treating like schizophrenia, bipolar disorder, those are gonna be
Well,
patients.
and that's
that
what
need to
I'm
be seen.
thinking
And
is
they're
what you're
usually,
gonna
they-
need for is more intense.
No, but you're even saying depression in older
Older adults,
right,
hard.
yeah.
That's a hard.
So questions around that, with time, we're out of time?
That's actually not what I was going to say.
Oh, okay.
I ran down, I'm glad that you guys went over, actually.
Oh,
but
okay.
The one thing I was going to say, you might have already touched on this, because obviously I haven't been here, is that Dr. Antoine, who you met, or he presented to you, he will be having weekly office hours for behavioral issues that come up, behavioral health issues that come up. So
You mean have patients come in?
no, I'm
Oh.
sorry, I should clarify.
Yeah.
Where he opens up a conference call line, and as a care manager or CHW, if you've encountered something, I know some practices already have behavioral health specialists, but as extra support, if the issue comes up of like, I have this patient and they're dealing with depression and they're older and there's some, it's very complicated to kind of give you some suggestions about maybe how to manage
What's his name
that.
again?
Dr. Antoine?
He's in your book,
Yeah,
he's
he's
our
in the book.
psychiatrist,
Yeah.
that's one of the company we were just talking about. Great.
So I don't know if that was covered, but we did just talk about it with the CHWs.
Good, okay. Well, we talked about depression, I didn't know about the weekly thing, that'll be great.
Yeah.
So hopefully that sort of thing will help. Katie, what was the thing I think Joe and I both took notes on is that there's a little bit of concern about that for some patients, the time range, the timeline for stepping up might be a challenge. So meaning that their sense is that patients may need some recommendations from our specialist core before the 3 months.
Before 2 months. So there is the step up from
Right,
1
we
month.
talked about that, yeah. Mhm.
Which is detailed, I think, in the slide set, reasons why they could be stepped at 1 month, which would be fine. The whole reason why we're not saying step right away is because we do want to see, some people we think might respond well to just having the care manager, I'm sure you already covered this, but just having the care manager interact and having someone be able to kind of quarterback their care and help facilitate that. And if we don't, from a research integrity standpoint, if we don't have just some time with just the care manager working with the patient, we're not going to be able to see if that was enough, what kind of effects you get just from working from the care manager. And so that's why it is staggered a little bit, but there's no reason why, if you know that this person, you're going to want that. I mean, you can get it going and get it ready, and it's just, we're going to say, like, at 1 month, that's fine. So if you're like, okay, it's 3 weeks, and I've got the form up, and you contacted Joe and be like, as soon as, this date, I'm ready for this referral, that's fine. And also because realistically, depending on when your patient appointments fall, it's not, it might not be just like that. So I don't know if that answers the question fully, but we've gone around this, a whole bunch of times about how soon we should be able to step patients up, because we do realize some people really need the help immediately, and it does come down to sort of saying, how will we know the effects of the care manager, what the care manager is able to maybe handle if we just immediately are kicking them up to care manager plus specialist, care manager plus CHW, and so we do want a little bit of time with just the care manager services. So why I ran down here, I don't know if we were wrapped up, but I ran down here in a fury because tomorrow it says that we're starting at 8:30, which is still right now the case, but there's the potential that we're going to start later tomorrow morning. And I'm just asking everyone, I'm sorry that I have to ask, but please check your email, the email that you've been receiving information from Chinema about the training in at 6 o'clock tonight. I'm sorry to make people have to check their email outside of the normal workday, but I just don't have confirmation about the start time, and so I would hate it if we push it back and you can check your email because we emailed after all of this, and then you show up here at 8:30, and you're like, what the heck, we are
But it
not
would be
starting.
this evening and not tomorrow morning.
Oh, no, we'll let you
Okay.
know. Hopefully I can let you know in the sooner the better, because
I hope so.
it makes me a little bit anxious. So hopefully you'll be able to know in the next 45 minutes to an hour. I just need to track down Chinema and Dr. Cooper and make sure that they will stamp off this plan to start later. So if we did start later, I'm guessing it would be around 10:15 instead of 8:30.
I would let us miss rush hour traffic. That would be a bonus.
Yes, yes.
Oh
You're
my
preaching
God, that
to
would
the
be a
choir.
godsend.
So I think that everybody would probably appreciate it. I just want to make sure that we're confirmed on
Western
that.
Maryland,
for
good
case
chance.
studies. So please, 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 please check your email tonight to make sure that you don't show up at 8:30 if we push it back. And we will
If that's
email.
a possibility,
We
I'll
will
check.
email one way or the other to confirm the time that it starts, because the last thing I want to do is cause you confusion about like, well, did they forget to email me?
So this is our last thing for the day?
Yeah, this is the last session for the day.
Okay, forgot it.
I don't have it in my phone.
This is it?
Yeah.
Oh, okay.
Yeah.
I know, because.
Can you guys, I don't know if you guys can text,
Hey, Kathy, give me yours.
because
Yeah.
I don't have access